Everyone, I would have been very happy to have a live case and show what Dr. Manikvaskam said, but it's very difficult to kind of transport a person interested that to a child with congenital heart disease. So I'll show some educative case. Blindly sitting and start doing a case, especially if it is of congenital heart disease, many times we miss some important features. So before you start doing the case, we should have something in mind. I'm going to look for these things. If these things are not there, those things I look for, something like that. So this 1-year-old child, symptomatic since 3 months, with complaints of fast breathing and feeding difficulties. Whenever there is a LV dysfunction, 2 things we should never forget, or we have to rule out is tachycardia, myopathy, and Alcapa. So what simple investigation helps? Say ECG. So this ECG shows abnormal Q waves in lateral leads. This ECG is almost looking like an adult ECG, which is very unusual for an infant. And this is very kind of classical for a person, for a child with LV dysfunction to have probably Alcapa. Many times a dilated cardiomyopathy also sometimes we have this kind of Q waves and tall QRS suggestive of LVH, but it's our duty to rule out Alcapa in this case. So straight away when I start doing the case, I'm looking for it. So this is a usual parasternal long axis view. And various degrees of MR will be seen, which is part and parcel of Alcapa. Various degrees of MR will be seen. And if you do the apical 4-chamber view, unfortunately I didn't get the apical 4-chamber view of this child, but this is from another child. And can you click on this? I can't click. Can you click again? See, these papillary muscles are echogenic. I have seen that this is there in almost 90 to 95% of children with Alcapa. Because the infarcted zone is predominantly lateral wall, anterolateral wall, than the pure anterior wall. And hence, the papillary muscles are always echogenic and there is always various degrees of mitral regurgitation. So, as I was trying to look for coronaries, already I am seeing some collaterals going through the septum. So it's probably a directed coronal branch. There is right coronary artery is also seen. Right coronary artery is, can you make this mouse operable? Okay, right, okay. See, it's easy for me. So this is a right coronary artery. Right coronary artery is mildly dilated and you can see some collaterals there. So further, you can see further collaterals into the interventricular septum, septal collaterals, and then some more collaterals towards the apex. Generally, we don't get these so-called collateral arteries into the interventricular septum. Rarely only you will get. So this finding further strengthens that there is probably going to be Alcapa. However, the main pulmonary artery and its sinuses were imaged thoroughly, but it was negative. Nothing was getting connected there. There was no flow into the pulmonary artery. But as the clinical suspicion was strong, the search continued. So I could image the coronaries. Can you see the coronary artery, left anterior descending artery there and circumflex artery there, and they seem to arise from the aorta. But if you want the circumflex artery, it's a red flow. That means this flow is going towards the aorta. How can this ever happen? Any vessel from aorta, the blood has to be away from the aorta, but here the blood is going towards the aorta. So I am not able to show the blood into the left anterior descending artery. So I am further reducing the scales. When I reduce the scale, it confirms that the blood also coming towards the aorta. The left anterior descending artery is blue and the circumflex artery is red. So their blood is coming towards the aorta. So obviously it's not towards the aorta. And further image, actually, in the dash light there is a small flame at this point. Can you see where I am keeping the pointer? There is a small flame. So actually the right pulmonary artery is there at this point, just behind the aorta, which is appearing as though the vessel is entering the aorta. So on further fine-tuning the image, now you can see this is the LAD, this is L circumflex, and then they are coming and opening the right pulmonary artery. Can you see this here? Can you see this here? So this is a Alcapa. Instead of usually arising from one of the pulmonary sinus, it is arising from the right pulmonary artery. So it was started on diuretics and referred for surgery. And subsequently, these are the things, caveats in diagnosis of Alcapa. The scarred and thinned out myocardium at the anterolateral LV. There is hyperechogenicity of papillary muscles, mitral regurgitation of various degree, dilated right coronary system, myocardial sinusoids, especially in the interventricular septum, are very prominent. absence of aortic origin of left coronary artery in minimum of 2 to 3 views. Color Doppler showing the flow in coronary artery towards the aorta. It appears as though towards the aorta, which is very abnormal and confirms the diagnosis of Al-Kappa. So the difference in collateralization and the severity of pulmonary hypertension are responsible for the difference in the clinical presentation. If there is reasonably good collateralization, LV dysfunction is not much. These patients will grow into adults or present with various degrees of mitral regurgitation as older children. If the collateralization is much less, they usually go for LV dysfunction. In this case, though we have shown the collateralization, there was LV dysfunction, child underwent corrective repair. So I'll just skip these things. Just one more illustrative case. 3-month-old child, asymptomatic, saturation 83%, single second sound, 3/6 ejection murmur. So this combination is very classical of tetralogy of Fallot, and it's a pink tetralogy of Fallot. So when I start doing the echo, I'm going to making myself that I'm going to look for tau. And this is the apical 4-chamber view. So we have two normal size atria, intra-atrial septum is intact. There is no interventricular septum. So just to keep your temporal lobe happier, I'm putting the other way also. You can see there is tricuspid regurgitation, not much of mitral regurgitation, but there is only one chamber, one big chamber. Most probably it's left ventricle. So I'm trying to look for right ventricle or the source from where one more great artery comes, which I am not able to get in the usual views. And when I go to the usual parasternal short axis, I am getting normally related great arteries. See, the great arteries are normal. I don't know why it's okay. The great arteries are not only normal, the pulmonary arteries are of normal size. The pulmonary annulus also is normal. The pulmonary valve is opening normally. Pulmonary artery sizes are normal. Clinically, I have diagnosed tetralogy of Fallot. Clinically, there is a good ejection murmur, but I have not been able to show where the stenosis is. And I also have not shown from where these individual great arteries are coming. So for this reason, as we have been repeatedly telling, one should practice the subject value. So this is our starting view of subcostal view. This is supravenous cava. This is right atrium, this is left atrium, this is hepatic vein and IVC joining here. This is the right pulmonary artery. Everything is normal in this view. And the moment you shift to the left, you see the entire thing is very clear now. The big thing is left ventricle. The small thing here is the rudimentary right ventricle. From the rudimentary right ventricle, pulmonary artery is coming. From the big left ventricle, aorta is coming. And the communication between the small right ventricle and the large left ventricle is very restrictive. Can you see that? And because it's very restrictive, this is preventing the pulmonary blood flow from being flooded, and hence this is clinically behaving like a tetralogy of Fallot. So this diagnosis will be single ventricle of LV morphology, severely hypoplastic, anterior right ventricle. There is a restrictive VSD, which is basically a bulboventricular foramen, and normally related great arteries. Sometimes when single ventricle has these normally related great arteries, we call it as Holmes heart. So because child was having a balanced circulation, relatively well-maintained systemic saturation, and he was just kept on medical follow-up. Okay, thank you very much.